Hello, my name's Richard Shilling from St Bartholomew's Hospital in London and One Welbeck. Welcome to Day 3, Session 4 of Rio 2022. In this session, the focus is on single-chamber leadless pacemaker systems with mapping capability, and Devi Nair, who joins us today, recently recorded the case at her center in St Bernard's Heart and Vascular Center in Arkansas, US. And I'd also really like to warmly welcome our panel members, Carina Blomström-Lundqvist from Uppsala in Sweden, and Mintu Turkia from California in the US. Welcome, both of you. So without further ado, Devi, let me hand over to you. And I just want to remind the panel and the audience that this session's live, it's interactive. So please do ask questions for the operator and the panel and for me, and we'll address as many as we can as we go. Without further delay, though, over to you, Devi, and your video.
Richard, again, it's a great honor to be part of Rio, and we're on day 3. So let me start with a little bit about the system as such. So today we'll be showing a case using the Avier VR technology. This is an Abbott system that became recently commercially available in the US. The Avier system is the second to market in the US. Of course, we've been using the micro system, and now we have the Avier platform as well, and it's a little bit different. And hopefully through the case, I can highlight the differences. But the design standpoint, it's a small device. It's a slightly larger device than the micro device from a length standpoint. The micro device is about 26 millimeters, whereas the Avier device is about 38 millimeters. From a weight standpoint, the micro is about 1.75 grams or so, and the Avier is about 2.4 grams. So slightly bigger device, but goes through the same outer French sheath. It has a active fixation device design compared to the tines that the micro has. So different in that standpoint. The delivery catheter obviously is also different. The platform actually has a delivery catheter and a retrieval catheter, so the device is actually retrievable, unlike the micro device. And we'll go over the catheter handle and what each of those do. The system also comes with, you can use your regular programmer, but with the Avier Link module that gets connected to the current programmer. So just a little bit on the device. It has, as I said, an active fixation helix. There's a tip electrode that has mapping capability. So you'll see me through the case that before I fixate the device, I'm able to map prior to deciding whether I need to move forward. It does have an X-ray code. It has that little radiopaque marker. It's a chevron that is used to decide how many turns you've done with the helix. And it has a docking mechanism, which is also the retrieval mechanism that you use to deploy and retrieve the device. Regarding the delivery system as such, you have the introducer, as I said, is a 27 French outer diameter introducer, not much different than the micro introducer. Regarding the delivery system, the handle is obviously different. It has a docking area with tethers at the end. You can see the tethers align with the device, and they come separate. The device comes separate, and the delivery system comes separate, and you actually dock it on the back table. And again, that has long-term implications, and we'll talk a little bit about it in a minute. There's a protective sleeve that comes over the helix to protect the helix and to protect the cardiac structures that can be moved forward. You can see there's 3 irrigation ports. They're all separately irrigated. So this is the valve bypass tool. This is the protective sleeve through which the contrast is injected. And this is the irrigation port into the actual device and the tethers. So the contrast really does not touch the tethers and such. So that's actually advantageous too. So that's the system as such. And the retrieval system is also pretty similar. The handle is very similar to what you would see with the delivery system. Obviously the tip is different. It's a triple loop snare that you would actually put on the docking part of the device and retrieve the device when needed. Both the retrieval system and the delivery system are deflectable, so they are steerable. You have a deflection lever and a lock mechanism, so you can deflect and lock it in place when you're in a good spot. So with that, I want to kind of go on to the case. Richard, what I've done is I've separated the case into a different subsection. So hopefully in between each of the section, well, we can come back together and have a little bit chat. So if I can have my first video. So I'll start a little bit with the history, but you'll see me as I'm getting access. We have just moderate sedation here with propofol. I do have a CRNA who gives anesthesia. All of my access is with ultrasound. Again, for a large bore access sheath, I think it's paramount to avoid any kind of vascular complications. So for me in my lab, small bore or large bore, it's always ultrasound guided access. It's there's safety, and to me there's efficiency. And I think once you have seen enough anatomies that are variant, I just don't feel the need to ever palpate and stick anymore. So we get our access with ultrasound. It's a generous skin nick because of the 27 French outer diameter. I'm actually starting with the 8 French sheath here because what I'll do is I'll actually pre-close. So I'm using a per-close suture-based system here. I used to use figure of eights for a very long time, and in this last year have kind of moved on to the per-close suture-based system, mainly because it allows me to have much early ambulation. And in this case, we're pre-closing, and we'll use 2 per-closes for that. We'll do one in what I call the 2 o'clock angle, and we'll come back with the second one and put it in a 10 o'clock angle, so to cover that large bore access. So you'll see me do the pre-closing, and while I'm going on with while the pre-closing is going on, I'll give you a little bit of history on this patient. He's a 84-year-old gentleman that has been known to our service for a very long time, has had chronic long-standing now permanent AF, has had multiple GI bleeds in the past, had a Watchman Flex device implanted for stroke prevention because he could not tolerate oral anticoagulation, was on AV nodal blockers, blocking agents, and recently had a couple episodes of syncope and a monitor showing significant bradycardia, currently off of his AV nodal blockers because of a significant tachybrady syndrome. And to me, this is an ideal patient who has a normal ejection fraction, has intermittent bradycardia with permanent AF, that is a candidate for a leadless device. He also has significant difficulties with mobility and stuff, and having difficulty with following instructions. So a great patient that does not have to follow instructions with the transvenous lead and shoulder restrictions and whatnot. So what I'm doing here is, after I've gotten the pre-close, I'm going in with the stiff wire. This is an Amplat super stiff wire under fluoro guidance. So through the per close, I'm moving the Amplat stiff wire into the superior vena cava. You can see the Watchman Flex device in the left atrium here on fluoroscopy. So once the wire is in, you can either serially dilate the access point, or I use what's called the Kuhn's dilator. The Kuhn's dilator is a taper dilator that you can, and I only have to use one dilator, so you don't have to keep going back and forth. So this is a 20 French Kuhn's taper dilator. So what I usually do is I'll put the dilator in place, and I'll get everything prepped. So right now we've come back to the back table to get ready to prep the device. So as I said, the device comes separate and the delivery system comes separate. So here the clinical team is actually opening the device. So you can see the leadless device is coming separate. You remove the delivery catheter from the tray and the device. It comes inside a kind of a loading tool, if you may. What I'm looking at is at the end of the delivery system to make sure that my tethers are aligned. And it's kind of hard to zoom in on that, but you'll have 2 tethers that you want to be aligned. You load it into you load those tethers into the funnel of the loading tool, and then you gently tug to confirm that that it's very well loaded. You unlock, open, and remove the loading tool, and you let that AVR device kind of hang on. You don't want that helix to touch anything on the table, so you have your scrub kind of hold it and let it just kind of dangle down as you go back and dock it into place. And so the advantage of this, I think, is that you can see me, I just docked the device in. There's a blue docking handle that you pull back and you dock using that control knob. You pull it back and dock the device in place. What I'm doing here is I'm actually taking the protective sleeve and I'm moving it forward to cover the helix of the device, because I don't want that helix touching anything, and I don't want that helix to cause any trauma in the heart as I'm moving up. So I cover the end of the helix, at least 2 millimeters beyond the helix, with that protective sleeve. You can actually test your deflection and test the braking system while you're in the back table as well. But the advantage of having the device coming separate is that hopefully in the future, when you're maybe thinking about a dual chamber system, maybe you could actually have 2 devices, use the same delivery system to actually put both devices. So that is kind of what the long-term implication of that would be. You can see us connecting the delivery system to the irrigation ports. So there's 3 irrigation ports, as I said. The first one is to the valve bypass tool, and that's just a heparinized bag to gravity. The second one is to the protective sleeve, that's a pressurized saline bag, and the third one is to the handle as such, which is also a pressurized bag because the lumen is extremely small. And once you have it all flushed and de-aired, you just let it all drip at about 1 drop per second. So this would be a good time for us, maybe Richard, to come back and kind of see where we want to go and take any questions.
Debbie, thank you very much. So let me start by asking you about the flushing. What's the consequences of not having this flush? Because you're in the right circulation. Are we that worried about flushing? What's the problems with that?
I think you have to remember it's a 27 French sheath. There's high chance of thrombus. You can get the tethers could get sticky. If you have thrombus at the tip of the electrode or the mapping electrode, you might not be able to map properly. So I think just to keep it less thrombogenic, it is important. Now, my patient usually. If I have a patient on oral anticoagulation, I only interrupt the anticoagulation for the day of the procedure. This gentleman obviously was not on any anticoagulation because he already had a Watchman Flex device in place. But even with anticoagulation in place, I still have the saline running. I don't routinely give heparin for the AVR implants. Because you saw me, I have not put the sheath up yet. I get everything ready. And then once I have the entire delivery system ready, then I move on with the sheath. So then it's a short implant procedure. If the implant procedure is longer, I probably will give some heparin as well.
Great. And Mintu, can I ask you, do you have experience of this nanostim pacemaker, or do you have experience of leadless pacemakers?
Yeah, mostly at this point at our institution, we have strictly been using Micra. Avir is coming up. I haven't done any myself.
And can I ask to you, we've been asked by the audience, does size and weight matter to you in terms of these devices?
Dave, you want to take that?
So I think the way I look at it,
because will it change your decision about which device you'd use depending on the weight and the size?
I would say no. I think the key unmet needs around this is going to be speed to delivery and then obviously AV synchrony. And so I think that matters. The safety data for Avir speaks for itself. And so, the comfort level, the learning curve, all of that becomes important with anything. I think Devi can speak best to her experiences with the form factors and weight.
I think, Richard, the question, I guess the size to me, the length actually to me matters a little bit about where you put the device, and we'll go over that in our coming videos as to, with the Micra, I kind of go to the mid-septum, whereas with the Avere device, I kind of aim for the low septum or the apical septum, so the back end of the device doesn't interact with the tricuspid annulus. So that is something you have to kind of keep in mind. But the weight really doesn't matter as much, because again, it is a retrievable system. So the idea is not to stack the RV with multiple devices. Long term is possibly going to be to retrieve them when the time comes to have a new device.
Great. And
so are there any
question,
differences
Carolina,
in user friendly? Are the two systems comparable with regard to the user friendly?
I think there is a learning curve to both of them. I mean, I think we all went through our micro learning curve. You have to kind of get used to the handle and what each does. But basically, the steps are pretty much the same, except for the fact that there are certain steps that are different where, you have to extend the helix and those things. But I think the learning curve is very steep.
Okay. Carolina, let me just ask you quickly. We've seen a pattern of everyone using ultrasound, or most people using ultrasound to gain femoral access. Is that your experience in Sweden now? Is that the direction of travel?
We're not using ice at all. It's very unusual in Sweden. So
I was thinking more about the femoral ultrasound to get access to the veins. Is that something you're using now?
No, we're not using it routinely, actually.
It's an interesting point that Devi brings. I think a lot of the consensus in the US, at least what we're seeing in also more clinical trials, is the use of ultrasound. First, it was reducing the variation of care, particularly in training programs and in July. But if you look at some of the closure studies, particularly the Vascade pivotal ambulate study, in that study that I ran with Andrea and a great group of investigators, the use of ultrasound was basically protocol. And what you found is even in the control arms, the observed complication rates were much lower. If you look at the vascular complication rates with AF ablation over time, they seem to have fallen in the US significantly over the last 5 years. We don't know if that's explicitly from broad uptake in ultrasound, but anecdotally, when we speak to our peers, it seems more and more people are using it in the way that Devi described.
Great. Well, we better move on to the next part. So, Devi, can you start telling us about the second sheath and delivery insertion bit?
All right. So, can we get that video back? Thank you. So at this point, we have the delivery system ready, and it's all connected. We're getting ready to get the Kunz dilator out. And getting ready to move the sheath or introduce the introducer sheath. Now, you can see my scrub Janet was she had the sheath extremely well. I guess lubricated is how I'd say. It actually allows the sheath to move up the IVC much easier. These are short strokes as you go up. I tend to watch the sheath under fluoroscopy as I am moving the sheath up. Again, having that generous skin incision really helps. So it's a real short counterclockwise motion over that stiff wire. This is usually kind of a little bit of the painful part for the patient. So usually I'll have the anesthesia team kind of give them a little bit of analgesia at this time, so the patient doesn't feel this as much. But you can see we have a little bit of scoliosis here, and I'm being very careful as I go up with that sheath. I mean, these sheets are relatively stiff, whether it's a micro sheet or an Avere sheet, so have to be extremely cautious as you move up, avoiding any kings on the wire and such. And you can see there's a radiopaque marker at the end of the introducer sheet, and what I'm trying to do is trying to get that introducer sheet to kind of the IVC RA junction. I don't need to go any further. I'll stop there. I'm taking the dilator and the wire out. Remember now this sheath is a large lumen sheath as well, so you want to kind of at least aspirate at least about 20 cc's and then connect it to a heparinized saline under gravity. it does not need a pressurized bag because it's a large lumen. But again, very important to make sure that the sheet stays connected to a nice saline bag to prevent any thrombus formation within the Now, at this point, you're getting ready to come in with the delivery system, and the protective sleeve is at the end, and you want to cover that protective sleeve with what's called a valve bypass tool. So that helps get through the sheet. So that white thing up here is the valve bypass tool. And what I'm doing here is I'm connecting a 50 to 60 cc syringe on the side port of that valve bypass tool. You can see the syringe is open to the tool. To insert the valve bypass tool, you can align the tabs and you just take a quarter turn and lock it in place. And in that way, it kind of stays in place and you keep that syringe port open. And as I'm moving the delivery system, you'll see kind of the saline going in. So it prevents any kind of air entry. And you don't have to fluoro for the first certain part of that entry until the second blue-gray marker. So the sheet comes in two lengths. There's a 30 and a 50 centimeter length. This is a 50 centimeter sheet, so you can go up to the second marker. For a shorter patient, you can obviously use a 30 centimeter sheet if you wanted to. But once you are there, you kind of you bring the under fluoro, you advance the delivery catheter into the RAIVC junction, and then you retract the protective sleeve back to expose the device. So what I've done is now I've exposed the device, and this helps kind of wake up the device. You can see the programmer screen up here. We're confirming telemetry and we're waiting to establish connectivity with the device. And so once the device is in the blood pool, that's when you establish connectivity with the device. At this point, if you want, you can actually program the leadless pacer to an appropriate rate or outputs that you want. The default setting that it comes in is VVI 50 at 2.5 at 0.4. So just to kind of keep that in mind. So here you can see I'm waiting on the connectivity, and you can see now we have connectivity. The green light over here shows that the leadless pacer is connected. And once that connection is established, now you want to cover that helix back up with the protective sleeve. And it's very well visualized on fluoro. You can see the protective sleeve over the helix. You want it at least about 2 millimeters past the tip of that helix, and you want to lock it. And at this point, I'll stop and take any additional questions.
Okay, one from me, Devi, quickly. Is the connectivity, is that RF, or is that have you got a wand over the patient?
It is not. There's no wand over the patient. They do have specialized. I guess they do have EKG stickers over the patient, but not wand.
Okay, that's wireless connection to the device then. That's pretty cool.
Yes.
Any comments or questions from Carolina or Monty?
How much heparin are you giving?
So in this case, I haven't given any heparin yet, and I don't plan to. So for the severe cases, for the micro cases, I almost always give heparin. For the severe cases, I've not given heparin just because we have so many irrigation ports that are all separate. Each of the lines are separate. So I don't routinely give heparin unless the case is, unless I have a very difficult implant and I'm in the RV for a very long time or something, which is a very rare thing. And then I might give heparin, but I really routinely do not give heparin.
There you had a question. So, with micro and the shorter form factor, as you said, it's very easy to be much higher up, be quite posterior on the septum, really easy to know that you're safely away from the septal free wall transition or the free wall itself. As you mentioned, with a slightly longer form factor and your recommendation to go a bit more distal, how easy or difficult is it to kind of be square on that septum and not on the free wall septal border?
I think it's a great leeway for us to go to the next video, because I'll show you how we kind of maneuver. It's a little bit different than how you would do the micro. So let me get on to the next video, and then we can kind of address that. So just just coming back to Mintu's question about entering into the RV. So I think it's very important to enter the RV low in this case. So I usually do it in RAO 30. And you can see I'll actually deflect the catheter by deflecting on that deflection lever here. You have the deflection, and as you enter the RV, I'll sometimes give a slight counterclock to enter into the right ventricle. You can see I'm causing ectopy here, and I'm kind of taking a pause, just letting it kind of settle in. But the key is to enter really low, and you can see that with the micro you're actually somewhere in the mid RA and kind of bending down, whereas with this one you're in the IVC RA junction and kind of advancing and kind of deflecting as you're advancing into the RV. So a little bit different in that aspect. You want to make sure that once you enter the RV, you're kind of clocking into the septum. So because you enter low, and just the angle in which the delivery system works, it takes you really to the septum. And you can see I've gone to LAO to confirm that I'm septal. Before I give any contrast, I'll go to LAO 30, make sure that I'm looking septally. And I actually like to go even further LAO, like a steep lateral over 45 degrees of LAO. Here you can see about LAO 48 to make sure that I'm really septal, because sometimes in the rotated hearts, we have enough evidence from like our micro literature that LAO 30 sometimes can be deceiving. So I'll come back to that LAO 30. I'm getting ready to give an angiogram. So making sure that I'm facing septally. You can see I'm not putting any forward force on it, so you really don't need any forward force. I'll give a contrast shot. You'll actually inject it through the port that has a protective sleeve. And you can see I'm not at the apex, but I'm at the low septum there, looking towards apical septum there. And I'll bring it back into RAO now and confirm that I'm actually in the low septum. The LAO really shows you that I'm facing septally. The RAO is what's going to show me that I'm really in the lower septum. So again, I kind of stick to RAO 30, LAO 30 for this implant. Here you can see the next angiogram, confirming that position in RAO as well. And what I'm aiming for is that low kind of apical position. So there's that low apical position in LAO. I knew it was septal. So once I'm happy with that position, I kind of have an idea this is where my annulus is as I bend. So I know that I'm away from it. So as I find that position and I'm happy with that position, now I'm ready to map. So I have to expose the mapping electrodes. To do that, I'm going to unlock and retract my protective sleeve. So you can see me kind of pulling that protective sleeve back. Here is the protective sleeve kind of being pulled back. I'll pull it back and lock it in place. And then we can do what I call the pre-deployment mapping. So now you have the device exposed. The clinical team is actually getting initial numbers. You can actually map, you can sense, you can get R waves, you can collect a baseline impedance, a baseline threshold. You can even get a current of injury. So you can see I have a slight current of injury, which tells me I'm not pushing forward. I don't have any forward force. I don't like to have a lot of injury before I implant. I'll get my R waves. I'll get my baseline impedance. So at least have, I'm starting at 380. So I'll keep an eye on it as I deploy the helix. So I'll know that it's almost like putting in a transvenous lead. I mean, these are things that we do when we implant a transvenous lead. So I think to me, this has been the game changer with this technology, is the fact that I'm able to map where I'm gonna go before actually deploying the device, because we know from the microdata that the higher risk of pericardial effusions and trauma to the RV comes from multiple recaptures and repositioning. So for me, this has been like a game changer, because the amount of repositionings, at least in my practice, has been very limited with the system, because we get to actually pre-map. You can also confirm the device movement with the cardiac cycle. You want to make sure you don't have any kind of buckling, any forward force. All of this kind of is done before. One of the other things that you would actually notice with the protective sleeve is you might actually see ballooning of the protective sleeve when it's in place if you're pushing forward. So these are some of the tips that you can keep an eye out for. So I'll stop there and before we go to the next video.
Great, Munsi. Does that answer your question about the positioning on the septum?
Yeah, that was great. And I think, again, as Devi said, one of the interesting new experiences with Avir is the real-time mapping.
So is it a unipolar or a bipolar signal?
Bipolar.
And Devi, does the parameters change after you've screwed in? Is there anything different after you've screwed in from the pre-deployment mapping?
Obviously, you'll have a much higher current of injury. You want to see your impedance go up. Your R waves might come down because of the current of injury. Your thresholds sometimes are a little bit higher, most likely because depends on your impedance and depends on your injury current. It almost behaves like your transvenous lead in a sense. But I will say that your thresholds are usually very low in the pre-mapping. If you're in a good position and you have good contact, if I have really low thresholds pre-mapping, then I know my tip electrode is in contact. Like I'm very confident about that. If my thresholds are high in the pre-mapping, I know that I don't have, even though I'm on the septum, I might not have enough contact. So I might actually move it in a little bit. So that's what I use the mapping for, not just to identify the location, but also kind of help do a little bit of contact mapping.
And do you, is there an issue with moving it to areas that are not the septum? Is there a risk of it causing problems if you don't put it on the septum? I would err towards going towards the septum just because it's a more thicker area in the right ventricle. I mean, the right ventricle is extremely thin, and you definitely don't want the helix tip to perforate. I think from a retrieval standpoint as well, it'd probably be easy if you're towards the septum and if your docking button is facing superiorly. So those are some of the things that I would keep an eye out for, because I'm thinking about this patient probably needing another device maybe in 15, 20 years. And if they do, then I want to be able to take it out, and you want to make sure that docking system is facing superiorly so you have access to it. So that's going to be the key thing in retrieval of these devices. So I think that's also something you have to keep in mind as you put these devices.
So you don't use the mapping capacity. Sorry. Can you use the mapping capacity in if you have a patient with a lot of scar tissue to look for another area, or?
Absolutely. So if I mapped in that spot and I did not like the numbers, I would put the protective sleeve back on. And then undeflect and redirect it to a different position, take the protective sleeve back, and then remap.
Carolina, I was going to ask you, what's the uptake of these leadless devices in Sweden? Is this now a common thing for the Swedish healthcare system?
I think it was some time before people started using the leadless devices, but we see an increase, and I think particularly in similar cases like this, but also in patients who's had CIED infections, they're preferring this kind of technology.
Yeah, and I guess renal patients as well who've had multiple venous access.
Yeah.
Well, should we go on to the fixation, testing and release part of your video then, Devi?
Yeah, let's move on to the next segment. So in the previous segment, I showed you that we had decided this was a good location. We had good numbers. So at this point, we're getting ready to fixate. So the first thing I'll do is I'll take a cine image to make sure that to know what direction my chevron's pointing. So what I'm using here is I'm using the once I have had the chevron mapped out, I'll know what how much I'm turning. And what I'm using is I'm using that blue control knob to turn in the clockwise direction. And it's almost 1 click per second. You can see I'm going very slowly as I'm turning the control knob in the clockwise direction, watching that chevron move. And what you do have to make sure is you pay careful attention to that torque transfer, especially in a very convoluted IVC. The torque transfer can be late, so you want to make sure that you're not rotating too fast. The pacer is not rotating too fast. Once it comes to a full rotation, I'll stop, let any of the additional torque that is built up kind of move forward, and then not go beyond 1.5 rotations. So you want to kind of stop at 1.5 rotations, and then once you're at 1.5 rotations, again, you're basing that 1.5 rotations based off of in which angle that chevron's located. So very important to have that baseline chevron angle mapped out before you start turning. So we have come about 1.5 turns, and now we're getting ready to go into what we call the tether mode. And the tether mode is where you brace that blue knob and you move the white handle back towards the feet of the patient. So this is what we call the tether mode. And once the tether mode is in place, you can actually watch the device to make sure that the device is moving with the cardiac cycle. You can establish kind of an anatomical reference of the helix's range of motion. And we're getting to do what's called the deflection test here. And what that is I'll deflect on the lever here to about 30 to 45 degrees. And you're making sure you can do it 1 or 2 times. And you want to make sure that the helix position is stable when you're doing that deflection test. So once you've done with that deflection test, you are getting ready to do your post mapping now. So you can see the impedance has gone up. The current injury was shown before, it was higher as well. So we'll keep, we'll look at the thresholds, we'll look at the sensing, again, do the entire mapping again. If you are seeing a lot of ectopy, sometimes just in the direction that it's sitting, you might have ectopy. You can actually adjust the docker based off of your deflection handle and make it more coaxial, so that while you're doing the retesting and all that stuff, so you don't get a whole lot of issue with ectopy. Now, in this case, we are looking at, I think we are coming down on our thresholds. We had very acceptable R waves, good injury, good impedance rise. I think we are at 1.75 here. So again, testing thresholds, we were at 1 pre-mapping. So all of our numbers seem good so far. You could say if your numbers are bad, you could reposition at this point if you needed. You could actually retract the helix back, put the protective sleeve back, and reposition it and redeploy it if you needed to. But the 3 things that you're looking for is good electrical measurements and good trends from your pre-mapping. You're looking to make sure that the leadless pacemaker is moving adequately and appropriately with the cardiac cycle. And then you want to make sure that you had a very stable deflection test. And once you have that, now you're ready to kind of release it. So what you do is you brace the delivery catheter handle and the blue control knob with your left hand. And I'm going to pull the release knob away, the white handle away from the blue knob, and turn it counterclockwise, just half turn counterclockwise, and that releases the device there. Sometimes it doesn't release with that 1 turn. You saw that in this case, as I turned, you'll see it in the videos replaying here, you'll see it release, and it's pretty evident when it releases because they both start moving in different forms. So sometimes you kind of have to wiggle it around a little bit. You have to move the knob a little bit, but most of the time it'll release pretty easy.
And if you have a problem with the device there and then, how do you have to just exchange for the recovery system to get it out again? Do you, once you've released it that way?
So if you once you've released the device and you have an issue, then you would have to take the delivery system that you had out. I would actually take it out. I would flush it because you're going to use the same system again to put it back in. So I would take it out, flush the whole system. I would flush the sheath, and then I would go in with the retrieval catheter, which goes through the same introducer sheath, retrieve the device back. You can take it out of the body. You can make sure there's no tissue or anything, kind of clean it, put it back in that loading tube that you had before. So one of the important things to remember is not to throw away the little loading capsule. So you can put it back in there, redock it back into your delivery system, and move back in as though it's a completely new case, but use the same system again. And I think that's a pretty good advantage, especially if you have any trouble after you release.
And you gave the impression that the recovery of these systems and these devices are actually not time limited, because my impression is with the Micro, after 6 months, because it's quite short, it will endothelialize and it may be difficult to get out. But the impression you gave is that that's not the case with this device. Is that correct, or am I misinterpreting?
So my experience in retrieval has only been one case of acute retrieval for a patient that we implanted that had the device kind of get tucked under the moderator band and having ectopy, so I had to kind of reposition it. But from literature, there's been AVR systems that have been over 9 years long that have been removed. I think the key to retrieval of an AVR device is going to be the accessibility to the docking port. And so when we implant, I think it's important to keep that in mind to make sure that the docking port is facing north or superiorly towards analyst. So when you come back in with it's not tucked under something or whatnot. So I think that would be kind of the key factor. But if you can get access to the docking port, I would think you could unscrew the device and kind of pull it back.
So I've got a question for Carolina and Munti. I'll start with Carolina first. The using these devices in young people in the hope that you avoid transvenous leads. Obviously, there's the dilemma, what do you do when that battery runs out and they've got many years of pacing ahead of you? What's your views on prescribing these devices in young people, Carolina?
Well, we haven't used them routinely in young people unless there has been an infection or some other reasons for choosing a leadless pace so far. So we've used it mainly in elderly patients and in infected patients.
And Munti, what about you? Is this ever a device that we'd use in young people? And are you worried about the legacy you create later on down the line?
In young children, there are certainly some advantages, but I think we're sort of early in that we're probably learning long-term leadless lead management, so to speak, as we figure this out. Over time, we are going to need to understand how you do take these out if needed 10 years from now, 15 years from now. We just don't have that right now. So the adult issue is what if you put this in and you're going to need some level of AV tracking. We have the other issue of defibrillators, and we know that Boston Scientific is addressing the leadless ICD unmet need with ATP from within. So I think all of that will converge, but I think it's too early. We're pretty early in the adoption of the maturity curve to understand long-term lead management. But I think we will have the tools, just as we have for transvenous.
And Richard, if I may jump in, I think. Yeah, I was going to add one more thing to both of their comments. Is I think one of the other differences between the micro device and the AVR device is the longevity comparisons. If from at least from the longevity estimates that have been, I guess, shown before, it's for the AVR system. Say if you have a patient that paces 50% and you're pacing output, say 1 volt or at say 60 beats a minute, 500 ohms. And you're pacing at, say, 0.24 milliseconds, you could potentially, or 0.2 milliseconds in the case of AVR, you could get up to about 24 years of battery longevity, which is a very long time. And if you look at ISO standards, there's definitely a longevity difference between the two devices as well. And the other difference between the devices, also the fact that you can potentially, there's a possibility of upgrading the device. So if you had a patient that you had infrequent need of pacing, just coming back to Mintu's point of needing AV synchrony and such, if you needed an atrial device, the dual chamber leadless technology with AVR just finished its enrollments in the US. So there's a potential that you could upgrade the system. So it's got the built-in upgradability feature. So this system, now this patient probably wouldn't need an upgrade. He's in permanent AF. But if for a patient that needed an upgrade that you were just putting in for, say, intermittent heart block, you could potentially upgrade it to a dual chamber system in the future. And so I think those are some important points to keep in mind.
Great. Well, should we move on to your last video, the delivery system and sheath removal?
Absolutely. So I think we have now deployed the device, and the important thing is retracting the system back. So I usually move that protective sleeve over. The protective sleeve is an extremely flexible thing. It doesn't really cause much trauma. So I like to have everything covered before I pull everything back. So I'll pull it all the way back until I meet resistance. And once you meet resistance, you can actually unhook the valve bypass tool and take it out. And what I always do is I'll get some images in RAO and LAO, but also come back to kind of an AP view and take an image in AP so that when I compare with the chest x-ray later on, I have some sense of where the device is in an AP format. And once we have pulled back on the delivery system, you'll see me unlocking the valve bypass tool and then getting ready to take the sheath out. Again, one of the things to kind of keep in mind whenever you're using these large bore sheaths is you have to have a plan in place for hemostasis. So as I said in my first segment, we had pre-closed it. So I'm wiring this the sheath back just in case I run into any kind of trouble with the sutures, the per-close sutures. So I'm wiring it back, taking the sheath back, and deploying the sutures of the per-close. I think the important thing is to make sure that you have some way of achieving hemostasis, whether it is manual compression or figure of 8 or whatever tool that you're using, just have it planned ahead of time, because I think that avoiding vascular complications is going to be key in these large bore sheets. Usually I'll give some lidocaine at the end because this is the time when the patient wakes up and that's really all they care about. They don't really feel anything else. So I'll give lidocaine at the end of the case, and you'll see that usually we don't have any bleeding or anything after our closure. I think that's about it with the case, and we can kind of wrap up on any final questions that we have on the system.
Great. Well, it's a lovely case. Let me, one of the audience has asked us a question, and I wonder whether I can ask Mintu to answer this. So they were asking about mapping and pacing parameters. Are you ever interested in ECG width when you're deploying a leadless device? Is that a problem for you?
That's really an interesting question. I mean, because this comes up with, can you get where you need on the septum to be pretty narrow? I mean, in my practice, we're not fishing around for various QRS width, and at least with a micro device, you're deploying first. So the idea that you can move it around so easily isn't the main strategy. It's to deliver it safely up on the septum. But Devi, now you have the ability to map in real time. I'm curious to know if you've tried this.
So I have not. I look at the QRS width, and it's really fascinating to see sometimes that even though the helix is not that long, you sometimes actually get a much narrower QRS. But having said that, I don't think if you're thinking about maybe capturing things like the conduction system, I don't think the helix is long enough to do that. But it obviously is potentially where the therapy could go, right? So I think I'm excited about the future where potentially maybe this device could give us a leadless conduction system pacing strategy, because we can map and we can target an ideal site. So not currently, but I'm hoping that in the future I have a tool that I could use it for.
I mean, that raises an interesting point that maybe I can put this to Carolina. Are you a believer in septal pacing and using traditional pacing wires Does that make a difference, or do you need a specific conduction system capturing device to make RV septal pacing of any use?
Well, I do think it's, as we know, difficult to capture and get a real septal pacing. So I think it's very dependent on the tools you use. But I was going to ask you another question, Devi, with regard to that you are actually able to capture electrograms. Couldn't you connect this system to a mapping system so that you can ensure that you're really in the apical position? Because I looked at the device, and to my view, it's a bit up. It's not in the very low part of the ventricle or the septum. You could go further down. So if you were able to connect it to a conventional mapping system, you wouldn't have to contrast injections and so on. It would be much easier.
I mean, technically, I think you very well could. You're right. I could probably go further down into the apex. I try to stay away from the apex as much as possible. I like the low septum, just because I feel more comfortable having a tool. I mean, it's a large bore tool going into the right ventricle, so I feel more comfortable when I'm on the septum than in the true apex. But having said that, you could use a mapping system. I guess costs would be the only thing that I think you'll have to kind of think about. Adding a mapping patch, or adding that would be difficult. But I think you could technically put a 12 lead EKG and kind of look at your QRS axis as you're pacing.
Yeah,
sure.
yeah.
But it is really simple to
Mintu,
do a little bit of contrast shot, and gives you a very good picture.
Mintu, can I ask you about your closure solutions? How do you close the vein after these types of large bore sleeves?
Yeah, I'm glad you mentioned that, because if you think about this from a patient experience standpoint, that's sort of the worst part, right? I mean, depending on what you do. So pre-close is great. I'm in a fellowship training environment, and so that you can do that, but often we are doing a figure of 8 suture with the old clunky way with the syringe 3-way adapter. And patients don't like that. Some of the other venous closure devices indicated for venous closure don't work here because this is too large of a bore. And so there is an unmet need still, in my view, to have very rapid, technically easy closure at the end of the case that can let patients ambulate right away and ideally go home right after that. What Devi showed is a great workflow that works, and I think a little bit better from a patient experience standpoint than a simple figure of 8.
And Richard, one of the reasons, I mean, you'll remember last year when I did the live cases, it was figure of 8, and I've kind of moved on to using per-close mostly for the patient satisfaction scores. I mean, the patients have really taken on to this technique, just because the ambulation's like in 30 minutes to an hour for most patients, and that has been the key. And also, we've had a large paucity of staffing issues, and so not having to have patients being monitored for 4 to 6 hours with the figure of 8, not having all the pain in the groin and all that stuff. I mean, it's a deal breaker in the lab now to have these closure systems. The patients actually go home within 2 to 3 hours as well. Before, I used to keep them overnight, and so and with figure of 8, I used to keep them about 6 to 8 hours, and now they go home in like 2 to 3 hours, and it makes a huge difference for the health system.
Caroline?
Agree. And also, I think you feel many of these patients are chronic AFib who get these, right? And so they're anticoagulated. And so the closure, I'm not aware of any head-to-head data, but early ambulation, seeing no bleed, I think you almost feel good enough to restart the anticoagulation that evening, definitely the next morning.
And Carolina, in Sweden, what closure devices do you use? Do you use anything?
Figure of 8.
Yeah. I mean, for us, cost is an issue, which is the challenge for us.
Yeah. But the dislocation rate, that is very low. So do you discharge all patients the same day, Devi?
Yes, for all of our groin access procedures, the patients go home the same day.
Mm.
So I think as we speak, in my mind, I'm clocking over the economics of this, because I know that our cath lab has to stop earlier than it needs to, because we need time to recover the patients before the day ward shuts. And I have to say that I did try using Perclose a while back, and I think the mistake I made is the trick is the pre-insertion of the Perclose rather than trying to do it after you've put the big bore sheath. Is that correct, Devi?
Yes, absolutely. I think you have much better control when you first get access. It's easy to deploy. Usually, I think the key to remember is pre-dilating with an 8 French sheet, so the Perclose goes in easy. And then just kind of cinching down the sutures at the end makes it a very, very simple workflow.
And what advice do you give to the patients after they've gone home? Do they have to do anything with the groin or look at the groin in any particular way, or?
Usually not. I mean, we tell them not to submerge, like go in the pool or something like that for the first week. But beyond that, we tell them maybe 2 days of not lifting anything super heavy. Tell them not to drive maybe for a day or two, but beyond that, nothing else.
And we've been asked by the audience, is there any role for echo or ice in these implantations? Do you ever use that?
So I have used intracardiac echo, but it has always been in conjunction with when I'm doing a laser lead extraction and having to implant a leadless system, an AVR system at the same time, because otherwise cost is an issue using ice for a leadless case. You really don't have to, but it's kind of beautiful to see it on ice when you actually have ice in place. Positioning is easy because you know where you're going. You can. I mean, the contrast use is very minimal. I mean, this last case, I probably used about 10 cc's of contrast. So you can cut it down even further if you want. But more than actually putting it in the right place, I think knowing that the docking button is facing towards a valve and is not hidden behind any structures is, I think, is more valuable on ice. Regarding like transthoracic echo, I think you could use it. It just adds in one more person in the lab, and one more person getting exposed to radiation with their arm in the field, and so I kind of take all those into consideration. If I have a tough case, I'll probably put an ice catheter up before I get a transthoracic imager in there. If I don't have ice, then I probably use transthoracic echo if I have a difficult case. But I don't think for routine cases you need it.
And Mintu, do you use any other imaging like ice or echo?
Typically not. It's usually, you have contrast and fluoro. That's usually been our approach.
I mean, I will get them to hand me the echo probe under the towel and have a quick look just to assure myself that the leadless is on the septum, but maybe that's lack of confidence on my part rather than the real necessity.
I try to do a very steep LAO. Usually even 90 degrees will go to that, and that has given me great confidence to look at placement. And also, at least with micro, the more proximal position enables you to be further back on the septum.
Super.
I think one of the differences is
I think
with the micro, you're having to push forward, right? You are actually having to put forward force to engage the device. But with this one, you don't really have to put a lot of forward force. So yes, being on the septum is important, but I think there might be less strength. Maybe there is less trauma because you're not really pushing forward either.
And is that just a consequence of the delivery system or the form factor, Devi? What is the reason you think you find yourself needing to push forward a bit less?
I think with the micro, you have to engage the tines. It's a passive fixation. And with this one, It's an active fixation. So you really don't need to push forward. As long as you have contact and you engage the helix, it will drive itself in. And the helix actually has locks that prevent it from torquing back. So it has little locks in place.
Thanks.
I think we're beginning to run out of time. I think it's been a great session, and I really appreciate the input from the panel. I think this case has shown us that Devi does wear lead occasionally, but she's a supreme operator in all aspects of electrophysiology. So we're all very impressed, Devi. And it's good to know that you're human and you do use X-ray occasionally. So thank you all very much. Thanks to Devi, Mintu and Karina. And we'll go on to the next session. So do please stay with us for the final session of Rio 2022.
Great case.